Okay, so we're going to get started right away. My name is Dr. Amira ICU. I'm a current family medicine resident and co-founder of AIMS. I'm really happy to be joined by this incredible panel. We're going to be talking about a few things today. So this is a health law, ethics, privacy, and fairness panel discussion, where it's going to be about 45 minutes long, and then we'll allow for about 15 minutes of question and discussion towards the end. As always, if there are any questions that you guys don't feel comfortable answering, please just say that you don't want to answer it and we'll just move on. But otherwise, I'm going to let each of you introduce yourselves and the work that you're doing right now. Would you like to start, Michael?
I don't want to answer that. So hi, everyone. My name is Michael Van Manen. I'm a physician in newborn intensive care. So my profession is I get to take care of babies for a living, which is the most wonderful job in the world if anyone's looking for a career change. And I'm also the director of the John Dossetor Health Ethics Center. My research program, as you mentioned, it centers around relational ethics, phenomenology, which is a tradition within the human sciences that many people identify with qualitative research or studying or researching lived experiences. So I've been involved in different kind of technology studies through the course of my career, not specifically in artificial intelligence, but more those technologies that come into play in the course of providing care to children and or infants in intensive care.
Good afternoon, everyone. I'm Nidhi Hegde. Currently, I'm an associate professor at the U of A CS department. I joined about 3 years ago, and before that, I spent, I'm not sure if I should say how many years, but most of my career in industry research. Most of it was in research labs in Europe. And most recently, it was at Borealis AI, which is a research lab with RBC. So because of my industry experience, I've worked on a lot of different kinds of problems. And it's really in the last, I guess, 5 or 6 years that I became more interested in machine learning and specifically privacy and fairness in machine learning. And that's my current research topic.
Hi again. Just in case someone just joining now, I just delivered the workshop on ethics in AI. So my name is André dos Santos. I'm PhD in computer science. I work for Amii as a machine learning educator, creating, delivering content in AI. Prior to that, I'm also an industrial engineer. Before working for Amii, I was a postdoc at the U of A for around 2 years, researching synthetic data generation for transactions, so in a partnership with a bank. During that time, I also did research on causality and actually to assess fairness metrics through causality. I'm also now recently part of the board of directors of the Health Trans, HG. I just remember the acronym, the Trans HCC Health Trans Collective. I'm missing one word there. No, there's no data. No. It's clearly I'm just joining the board. I'm still learning about operations, but it's a great non-for-profit that helps men and trans men specifically, and queer people. HK, Queer Trans Health Collective. Got it. And yeah, that's my experience around that. And then at Amii, I'm focusing more on ethics in AI, which has been quite interesting role because there's no right answers, but it is impactful, and then it's more and more Amii is being asked to talk about that, and I enjoy doing it, so it's great.
Awesome, thank you. So I think, why don't you keep the mic? I have a question for you and your synthetic data.
Yes.
How do you, don't look so nervous. How do you think that would apply in healthcare, creating synthetic data?
That's the thing, that's actually quite correlated. When I was doing the research, because the idea of bank, lots of transactions. What can I do with the transactions? Nothing, because I don't know about you, but I'm very protective on my transactions, right? But there are benefits of AI, right? That you can do a lot of things with AI. If an AI can tell us like, hey, you're spending a lot on McDonald's, maybe buy some lettuce. It would be great. No, not to the level. I'm kidding, of course. But if there's opportunity there, should we do it? In that sense, they wanted to do a synthetic data where we just get a distribution over the transactions. So internally, it can be researched. So I have to go sign NDAs and like a lot to get access to the data. And there was billions and billions of like one entry for each person has like each transaction has the time was registered, credit card or not. Like so it was considered a panel data. So it doesn't have just one dimension. It's just there's time, but there's also profiles. So it was quite challenging. I had access to a supercomputer and I got to create the profiles and see the patterns of people. But the same was doing research is quite correlated to healthcare because we also have a lot of data in many different dimensions and also time. And which is interesting now, I'm putting all together because through causality, I work with the initiation and AI initiation planning at Amii with the companies, and one specifically is dealing with medical data. And they want to say, hey, what can we do about it? It's like, first of all, make sure you can use the data. That was the first concern. And then later, okay, with that data, my concern was, are we just finding correlations towards the issues here, or are we finding the real causation around that? But the challenge is it's a lot of data, and the way you analyze that, there's no right answer because first of all, not a lot of researchers have access to this type of data. So there's no right answer. When I constructed, I have to adapt ways and different models to capture all of that. But it worked to some extent. It is still ongoing project because, and here's the challenge on the Pareto like distribution, how utility versus privacy. When do you know when to stop? Because if it's very private, it's basically white noise. Like there's nothing. But if it's very useful, basically you can triangulate each transaction, or in this case, each patient into the data set. And that's a discussion that needs to be ongoing. And we need to find all the metrics to make sure a person cannot be triangulated and found on those models, as I think was part of the discussion in the workshop before.
Great, thank you for that answer. So Nidhi, you also played a lot with data and data privacy. Can you tell us a little bit more about what that looked like in your careers?
Yeah, so I don't think we've done anything with privacy and healthcare data, but in other types of data, we've done it, for example, for recommendation systems, where the issue is that you may have some data that's useful for making the recommendations, but you may not want to infer other things that, that data wasn't intended for. So we looked at it in a framework where you could provide some sort of guarantees, and we were able to use, tools from information theory and other things to be able to guarantee privacy. So that was interesting. I don't know if it was ever implemented anywhere, so I don't know what actually happened with it, but this was when I was working for a company called Technicolor, so they were interested in, movies and recommendations and stuff. So I don't know if they ever used it. But in other work, there are other ways of ensuring privacy, not just by this specific mathematical guarantees that you can have, like splitting your data among different servers or different entities that don't share data with each other, things like that. So that is possible. In terms of healthcare data, I think it's a little tricky. Because a lot of people in machine learning, when they talk about privacy, they're talking about something called differential privacy, which is a specific definition that ensures privacy by adding some sort of calibrated noise. So there's some kind of perturbation on the data. And this noise is calibrated according to whatever you're looking at, the data you're looking at, the task you're doing, and so on, and the utility that you want to get in the end as well. But it works really well for certain situations. And, you really need to examine what the context is that you're using. For instance, a few years ago, there was a case study where they used it to test. They didn't actually implement it. This was just a study that they did to see if they could use differential privacy for warfarin dosing. And it was a disaster because the dosing that was being predicted by the tool was, all over the place. And obviously warfarin dosing is a very important thing to get right. So that was a case where differential privacy was definitely not the answer. So it really depends, on what kind of problem you're asking, what context it is, what kind of data you're using, and so on, when it comes to using, known mechanisms of privacy in healthcare data.
So it sounds like nobody wants their personal healthcare data to be leaked. They want it to remain private. I'm just wondering, in the context of being hacked, we've seen machine learning, something called adversarial machine learning attacks. Have you ever seen those, and what do those look like?
So if I understand what you're referring to, there is adversarial machine learning where there's an adversary that tries to there's one form of adversarial machine learning where the adversary tries to sort of poison the data or sort of create data that looks like the real data, but it isn't, and it somehow interferes with the training process, and so you don't get the model in the end that you were expecting. And this can happen also because these days, a lot of times, there's a lot of retraining of models going on because the data itself is changing. There's something about the data distribution or population that's changing. So there's retraining going on. And so if in your retraining, you're trying to retrain according to this data that you don't know is from an adversary, then you end up having a wrong model. And so you could imagine in this situation that our adversary wants you to have a certain kind of model so that some actual data of theirs maybe gets a output that they're looking for. But how to avoid this or how to mitigate impacts of this kind of adversarial attacks is a research question right now. So a lot of people are working on how to make systems more robust. Now, robust is a very sort of general term. You can use it, you want your system to be robust to privacy leaks. You want it to be robust to these kind of adversarial attacks on your data. Essentially, you want it to be robust to any kind of perturbations that can happen on your data. And that, can be easy or difficult. It depends on the kind of data you're talking about, the size of the data that you're starting with, and so on.
Great, thank you for that. Sorry, go ahead.
Sorry, at one point you said that no one wants their healthcare data to be made public. Is that right?
I may have said that.
Yeah. No, but I think it's actually something important to actually question. There are actually many patient groups that do want their health information, at least their stories as patients, to be made public, right? To often better the care of other patients who have similar conditions. And we run into those issues in pediatrics where it's particularly challenging because often parents want to share their child's story and their family's story with other families who are faced with children with similar medical conditions. And often these children are extremely identifiable. When I think of the work I've done with children who have tracheostomies on home ventilators, or kids who have ventricular assist devices or mechanical hearts, we can identify these kids very easily from their stories, yet the parents want to share these stories with others to support better healthcare practice. So we have to be careful when we start with the assumption that everyone wants to keep their data private. Some want to share their data and the data of others in their family.
To some level, we are sharing, like if you have a smartwatch, lots of people have collectively part of that. So there's some interest on sharing your data, and like, especially on fitness, a lot of people share the information. It's not like, I don't think you're right. Not everyone wants, it's not 0-1 as any case, all cases. I think some sensitive information depends on where, on whole idea, which information we're sharing could be problematic.
Or they want it shared for a particular purpose, which also becomes very challenging, right? So when a family consents to the sharing of their information, but it's now used for a secondary purpose, and then they get uncomfortable with how it's being used. So that introduces different ethical dimensions to this.
I stand corrected.
And it's not a question of corrected. I mean, it's just, I think it's important when you're talking about the ethics of something, you're trying to open up understanding as broadly as you can, rather than prematurely saying, oh, here's the solution or here's the problem. You're trying to see it in different lights.
So Michael, you spend a lot of your day kind of talking to patients and talking them through what the next steps are in their management. We're kind of moving away from this paternalistic way of practicing medicine to a more patient-centered shared decision-making lens. I'm wondering with machine learning, you kind of, Andre, you talked a little bit about explainability and black box. I'm wondering, what would that look like for you as a physician? How do you feel about explainability of AI?
So I imagine myself sitting over a little baby's bassinet, looking at them and saying, all right, I want to talk to you about this thing called machine learning. And the baby's looking up at me with a breathing tube in, kind of just joking. Because I mean, that's something that I have to acknowledge, that my patient is this child who doesn't have autonomy, who can't speak for themselves of what's in their best interest. So I approach the decision-making of my patient through their parent, which is in itself always an ethically challenged situation. So coming to your question is, how would I speak to a parent about machine learning? Is that right?
Yeah, because I would imagine the conversations that you'd have with the parents, you'd need to have some sort of management plan or suggestions and explanations as to why those suggestions may be best for the patient.
Yeah.
What would that look like if your machine learning algorithm it was not explainable? It's a black box.
So that might actually look like some of our everyday conversations we already have now. So sometimes we have children who have a particular complication. Maybe we find out a child had a stroke over the course of being in the NICU, and we're not sure when that happened, how they formed a blood clot and how it ended up into their brain. And we can think about different factors or features that may have contributed to it, but ultimately it's not clear how that happened. Same thing around birth complications, for example. So already when we're counseling or talking to families or patients, we're dealing with issues around ambiguity and uncertainty. That's part of medical practice. The other thing that's important to acknowledge within medicine, many of our diagnostic categories that we use also have uncertainty with them, right? So we come up with diagnoses because we think it improves the care of our patients. So if I can name a particular patient's condition, it's because now that affords the use of a particular medical therapy or for me to disclose a particular prognosis. But many of our diagnostic categories over time change or become refined or become developed. So in a way, we're already in a state of constant learning and uncertainty.
So as a physician, I would imagine the families have quite a bit of trust in you. So if you were to suggest something, they would trust that you went to school for X number of years and you're able to counsel them accordingly. Do you feel like people would trust you saying that a machine learning algorithm did this? Do you feel like they would trust the machine learning algorithm?
I don't know if I can speak on behalf of all my patients about whether they would trust me. I do think you're right that generally healthcare providers, and I think it's probably better to say that nurses have more trust than actually physicians do from patients, particularly in Alberta for some reason. I don't know why that is. So we are in positions of trust because there's an expectation that we have our patients' interests first and foremost, right? So as a physician, I don't benefit. I'm not paid more if a patient agrees to have surgery done or agrees to take a particular medication. I have a fiduciary obligation to them that's also reflected in nurses. I think if I were to say, there's a particular pattern I'm seeing here that puts your child at risk in the long term, and that pattern is being deduced by some kind of an algorithm. And because of that, I think we need to explore this particular intervention or this particular test. I think families would probably accept that, but they would also have to know that there is some foreseeable benefit, and that benefit's also taking into account the risk. So for example, I know there's some machine learning being developed around the continuous cardiorespiratory monitoring we use for babies. And we don't really know, we can't explain the pattern changes, but we recognize some changes in pattern are associated with early onset sepsis or signs of a bacterial infection. So if we were to say, look, we're seeing a change in the pattern here, we think that there's a foreseeable benefit of poking your child for blood work and starting them on antibiotics, knowing that there's some risks involved. I think many parents would appreciate that, provided they knew that the benefit outweighed the risk.
Thank you for that answer. Nidhi, how do you feel about explainability of AI?
How do I feel about it? It's tough to say. I think we want to know how a decision maker came to this decision, right? In general, so you would expect to be that there be an explanation of some output that a machine learning model gave you. But there are people who say that it's not always possible to pinpoint exactly why that output is the way it is, because models are more and more complicated. If you've got like a neural network model, you may not necessarily know what led to that output. I mean, you can look at the parameters that were learned and the weights that were learned, but does that necessarily mean something? And then there are people who say, well, that's the whole point of a machine learning model, is that if we knew that there was something that had an impact on the output, then we wouldn't need a machine learning model. So, but that's of course unsatisfactory, because we do want to know, especially when it leads to a decision, and you may get decisions made for a set of people who might think they are similar, and yet they may have different outcomes. And this happens a lot. There are many cases like credit loan applications, judicial systems, and so on, where it's a little bit inexplicable how certain outcomes came to be, especially when people who are similar in what we think matters for that outcome end up getting different outcomes. So I think it's important to be able to explain. I don't know if it's important to be able to pinpoint exactly how a decision came about, but maybe an explanation could be that, well, people who have, I don't know, I'm just making up an example here, people who have had their first event or incident with their heart disease at an age before 30 and had this, maybe their prediction has always been, A, whatever the prediction was. And therefore, that's why your outcome is such and such. It could be a several set of factors that could lead to an outcome. And maybe an explanation like that might be okay for a medical or a healthcare framework. But I don't know that we're there yet when it comes, especially when it comes to the more complicated models that we have. I don't know that we're there yet in terms of even being able to say approximately with confidence. You can always, there are methods out there. There's lots of methods out there for explanatory machine learning, but is it able to give you this explanation with confidence is maybe a question. Because if you're going to use that to then make other decisions, then you want to know what the confidence level of that explanation is as well.
Yes, absolutely.
There's also a certain moral acceptability about certain factors that are fed into a machine learning model. So to give you an example, in my world, when babies are born extremely premature, so weighing, 500, 800 grams, we know that there are certain factors that are associated in the long term with mortality. Two strongly associated factors are sex, as well as whether the baby is outborn compared to inborn. So, to say plainly, little baby girls who are born in Edmonton tend to do much better in the long term and are more likely to survive compared to little baby boys born in Wetaskiwin or Wabasca or somewhere outside of the city. Does that mean that it would be ethical for me to offer a different level of care to girls compared to boys, or urban Albertans compared to rural Albertans? Can you imagine what Daniel Smith would say, right? So, even if you have the perfect model, right, there is also a certain moral acceptability about what variables you can actually act upon or use as a variable to predict outcome, because that would be discrimination.
Okay, so we're just gonna take a little bit of a brain break. I'll ask each of you a question. You may provide an explanation if you'd like. So Andre, do you have any conspiracy theories?
Okay. Conspiracy, no, conspiracy theory, no. Which for me, which is interesting that I like. Oh, it's completely off topic. Okay. I do not believe, that's not true. I'm in contradiction. Such, okay, for instance, I follow zodiac signs. And here I'm explaining because I already there's a
Zodiac sign.
Aquarius. And here's my scientific explanation to it. Good?
It's like a dating show. You can say you're not comfortable to answer, just letting you know this.
Here's my scientific explanation. It's not like I try like, oh, because the moon is there, I was gonna make me do stuff. It's not what I believe, it's not the causation. But I do believe humans follow a pattern. Overall, this history repeats itself. And I think because of that, like if technically in a control environment system, if you know the position of every single atom in a position of time, you could predict when it's going to be in the future or where it was in the past, right? In the control environment. We are humans, we're tiny, tiny items in the huge universe, which can theoretically be part of huge equations. And part of these huge equations are the planets there. And then I'm saying that one affects the other, but my conspiracy theory is that we humans, we follow patterns. And I think it's important for us humans to look back at the history so we don't repeat the same mistakes.
You're an Aquarius.
Social justice warrior, yes.
Okay, thank you for that. Nidhi, what are some things on your bucket list?
My question is different.
Well, bucket list, like just in life in general?
In
Bucket
general.
list? Oh man, there's so many places in the world I want to travel to. So there's too many to name, but there's a whole bunch, and they're all on my bucket list. I'll need to find time to do that first. I don't know when that's going to happen.
Let me know if you need a sick note.
Yes, I'll keep that in mind. Gee, I really can't think of much else right now. Travel is like the big thing on my mind these days because of the last 2-3 years. Yeah, I'm gonna stop there. Yeah. I think that's
Okay,
pretty much
thank
it.
you.
Anywhere specifically want you to go?
Well, I want to spend a whole month in Japan. I haven't spent that much in Japan before. There's a whole bunch of countries in South America that I'd like to go to.
Brazil.
Brazil's great. I've been to Rio. Yes. In the African continent, also, there's a whole bunch of countries I'd like to go to. I like to see these conferences that are in more and more in the continent of Africa, because then I can maybe sneak off for a few days. Northern countries, actually, I haven't been to beyond the Arctic Circle at all. And there's apparently this place in Finland. It's this camping environment they have like way up north, and you can cross-country ski like several kilometers to the village, back to the village, and it's all sort of like an igloo kind of environment. I can't remember the name of it right now, but it's been on my list for a long time. So yeah, places like that.
This all sounds very exciting.
Yeah.
Yeah, thank you. Michael, what kind of music are you into?
Oh, I got an easy question. This is great. I listen to a lot of classical music and I listen to a lot of jazz music. I've played in jazz bands and funk bands. I've played professionally as well.
I have many questions for you. Okay, tell us about your jazz band.
Oh, which one? So here's a cool jazz band I played in back in med school. We were such geeks. We thought, you know what, we are going to be able to pay our way through med school if we, come up with a cool jazz band name, and we're hired by, surgeons who make a lot of money to play in their houses and stuff. So we called ourselves Virchow's Triad. And Virchow's triad, for those of you who are studying for your medical school exams, probably not tons in this room, are the factors that are associated with a blood clot, right? So hypercoagulability and stasis. Yeah, there you go. It's a bit of machine learning.
Sounds like your hot stoppers.
Oh yeah, I think our biggest gig was playing at a Nissan car dealership opening, which paid extremely well, which is nice.
I'm very happy to hear that. That's very cool. Okay, back to business. Nidhi, how can we make AI more fair for everybody?
Oh boy, that's a complicated question. There's so many ways. I don't know if there's one solution. It, has to encompass like everything about AI and machine learning, right? It starts with having the right type of diversity in the teams that are designing these tools, who they're designing it for. It's about the data that's being collected, how was it collected, when was it collected, who was it collected about. There's also all the data processing, and then, even asking if this is the right question to be solved with machine learning. It's not necessarily the answer for everything. There are some things that maybe you don't want to use machine learning for, just because you don't really know how, what kind of a solution you're going to get, right? Like hiring, for instance, maybe this was an example that you had in your workshop, hiring. Maybe machine learning is not the answer there, right? So it starts with that, like what kind of question you're asking, whether you've got the right model for it, and all that. So it starts with making sure that you understand, the entire pipeline, the entire process, and whether things are appropriate for the question you're asking. And then, yes, there is going to be bias. If you have not taken care, there might be bias in the data because of the way it was collected, because there was bias historically, and that's what's being reflected in the data. So you do need to look into, and it may not be sufficient to just de-bias the data. I'm not even sure what that means. A lot of people say it's just the data, that's all. If you de-bias it, it's fine, but we don't know how to de-bias data. Some people think that that means you're just balancing the data, meaning that you're making sure you have the size of your subgroups are the same, whatever your subgroups are, male, female, other gender, it could be ethnicity, whatever the subgroups are. But that's also not sufficient. I don't know if this was an example you used in your workshop, but there was a study done called Gender Shades, where they had balanced data. It was a facial recognition study. They had balanced data in the sense of male, female, Black, and African-American and Caucasian. And then they took facial recognition software that was available at the time, the Amazon one, Microsoft, and I think IBM. And even with that balanced data, all three of these tools had very high rates for Black females compared to white males, for instance. So even with the balanced data, there was something else that wasn't right? And in that particular case, we could probably say, okay, well, these are images that were captured by certain mechanical tools that were likely optimized for a certain skin tone. And so there's more precision in a certain skin tone than in others. And that could be what it is. But it could also be the actual machine learning model that took those images and then created a representation from those images. And then from that representation, you have the recognition, classification, and so on, right? So even just the machine learning model, there's several steps in there. So there's several entry points for you to actually try to mitigate the bias. So it's not just the data, it's, the model maybe, and we don't, you may not know exactly where in the model. So there's a lot of investigation and a lot of things that you have to do in order to mitigate fairness, uncover fairness, unfairness. Yeah, so I guess that's kind of a vague answer, is that it's, it involves everything. And so you do have to look everywhere.
Thank you for that. Andre, how do you feel like we can use AI to make healthcare more accessible?
healthcare more accessible? I don't think I can answer this question because I don't know what takes to make healthcare accessible. From my standpoint, is uh, we need to make it more accessible regardless. And I don't know if the AI is that tool, that interface that will make people more accessible. Definitely can help healthcare professionals to improve their job. And I think ChatGPT is one example that just come to life and everyone's talking about, and there's a resistance, but it can be useful. It is, the thing is, we do have to, I think the power to be useful, to make the work, the healthcare workers better, more efficient, it's there. But then there's another conversation, is who holds the power, who holds that the model, and then what the model was created on, who's being affected by it. Because in the end, I think the answer is we need to talk with the people that they're going to be affected by it. So do even people want, like, to be assessed by it in AI? Do we want do the healthcare professionals want that help, right? Is that, because sometimes they don't need that. They actually need some better salaries or more time or a 4-day work week. And we are aiming at AI to solve everything. And there's other concerns that might even be cheaper if you just listen to the people.
Yeah, absolutely.
Just
Thank you, Andre.
Just a quick point about that. A lot of times when people talk about AI healthcare, they're talking just about the care part of it, but there's also the management part of it that uses a lot of data. AI is kind of a umbrella term used for many things. So I don't know if they're using AI, but they're definitely using data in making their decisions and policies and so on. So having the right data to make sure that healthcare is accessible is important, right? For instance, if you know that babies in rural Alberta premature babies in rural Alberta have a harder time making it, then there has to be a policy decision made to study that and look into that, right? That's one way of making things accessible. And the other is to make sure that you have the correct data to make that determination. And one quick example, and sometimes when you're trying to solve one problem that AI has caused, you're creating another problem. And one example of that is that the last US Census in 2020, I think it was, used differential privacy, which is a way of ensuring privacy in data in releasing that census data. So typically the census data is collected and then released at certain county level, city levels, county levels, state level, and so on. And then this time they used differential privacy before releasing this data. So they thought, okay, this is great. We're going to help everybody. We're going to, keep their information private and so on. But then there was a group of researchers. I don't know which department because everyone's doing interdisciplinary work these days. There's a group of researchers that was using this kind of statistical data to show that certain subpopulations did not have good access to healthcare in certain counties in the US. And their job became even more difficult because of the way that the privacy, as I said earlier, it's usually done with perturbation or calibrated noise. The way that was applied, the certain county level data they were using was too perturbed for them to make this claim about healthcare being inaccessible to certain subpopulations. So that's one thing, making sure you have the right data that you're using to make that, make the policy decisions.
Just one more item is that we talk about explainability, but interpretability of the models is often AI. We default to machine learning to learn from the data and see the underlying connections among factors. But their own AI itself, there are other tools that are inherently transparent. They're sometimes simpler, not necessarily accurate, but would aid healthcare professionals way more if you can trace back, okay, the machine did this decision because this decision, it will be way more informed decision than machine learning has a high accuracy but have no idea, because sometimes that 1% that is wrong could be terrible.
Okay, well, thank you for those answers. I have one for you, Michael. So we know that, like, the pillars of medical ethics, one of the biggest ones is non-maleficence. So if we have technology that performs better than the average physician or can do something that most physicians cannot do, would you be doing harm by not utilizing this technology?
Would I be doing harm? Sorry, there was a lot of like, would I be doing not harm by not using? Sorry. So if as a physician, there was a technology which I had access to that could potentially improve the outcome of my patient, would it be ethical for me not to use that technology? Is that what you're saying? Well, I think you answered your own question. I don't think as physicians that we can be gatekeepers to what our physicians do, or sorry, what our patients are or are not afforded because of our own beliefs. These are ultimately patients' decisions, not physicians' decisions. So we have obligations towards ultimately supporting patients with whatever means will best support them.
So how do you balance that? So let's say we have a physician who doesn't quite understand the technology and they don't quite feel comfortable using it, even though it's been shown to function very well. How would you balance not understanding the technology with using it despite the evidence?
Sorry, can you repeat that one more time?
Okay, so let's say you have a technology that works really well. It's shown, all the studies show that it works great. Some physicians use it because they understand it and they trust it. Other physicians are worried about using it because they don't understand it. So those physicians are trying to balance their understanding of that technology, and they don't feel comfortable using it because they don't understand it. So what would be kind of the ethical things that come to mind in that situation?
Okay, so I think when new technologies are brought into clinical practice, right, there's always going to be early adopters, and there's going to be others who are going to take a more circumspect approach, recognizing often research that's out there that favors a new technology can be subject to certain biases as well, right? So it's not unusual. We hear about something going to be a very promising new drug or whatever, but it doesn't pan out over time. So I do think if we have a group of physicians or nurses or other healthcare providers who are reticent on using a new technology, we should take that as an opportunity to actually say, you know, what's going on here? And I think looking at it from different perspectives is ultimately taking an ethical lens to a situation, because it very well might be that whoever is saying, how come these physicians or nurses aren't using this? They're actually missing something from the picture. So I think it's an opportunity for reflection.
Can I just offer a technical perspective? So a lot of machine learning tools these days, we don't really have an understanding of the uncertainty in the output from that model. So if we had a better quantification of that uncertainty, and we know that humans have some sort of uncertainty in the decisions they make, so maybe that's something that should be compared, like the uncertainty of what a physician may have in their decisions and the uncertainty around a certain output from that AI machine learning tool in order to decide whether you want to use it or not.
Practically, what can often, help healthcare providers who are reluctant towards adopting some new technology is for it to be rolled out as either a quality improvement or quality assurance practice, because then they know that as this new thing is being brought into practice, there are some safeguards there for their patients. So if there are issues identified, they're at least tracked and disclosed over time. So.
Okay, well, thank you so much for your answers. We're kind of nearing the end of the panel discussion. We have about 10 minutes for questions. Can we have one more round of applause to our amazing panelists?
Great conversation. Thank you so much. I had a question regarding what we touched upon in the beginning regarding synthetic data and generating data. Now, specifically in the medical field, I know there's a lot of interest in generating synthetic data, not due to consent specifically, because in a lot of medical fields, you are able to get consent from patients, but more due to sample size, that we want to artificially boost sample size in order to make critical decisions. Now, my question then comes a little bit from The limitations of sample size are often due to either cost or rareness of disease. Imaging technologies, for example, are very expensive, so we can't scan everyone. So we have limited sample size available there. Now, when we have a data set, we kind of need to make an ethical decision whether you're going to go for a very diverse data set, which is very complicated because you don't have that data, which means you're going to have to artificially boost minority groups. Or you would go and take the other approach and say, I'm going to use a more narrow distribution of patients that are more likely to occur in my data set and only predict for that specific set of people. So my question is like, what is the ethical implication of that if you either choose, I'm going to go for a very diverse data set, trying to include as many people as possible, and then do synthetic data generation on that, or you're going to make your distribution more narrow and selecting the most occurrent cases that you have, and then boost your data set like that, and then actually try to create a separate model for different minority groups.
I think both of those have pros and cons, right? The idea of going with the diverse data set and using synthetic data generation to boost the minority population. I don't think it's as straightforward, and this depends on the data. For instance, the synthetic data generation tools that are more common these days are like GANs, for example. And I guess they work well for images, but then if your goal is to boost the minority population because there's this diversity, then you need to know if the GAN that you're using to generate the data does take that into account. And we don't really know that. Like if you already have a small sample size, it might be hard to train that GAN already. That's one issue. The other is if it's not images, if it's other things, like maybe your data set has, you know, blood test analyses or other kind of continuous variables like real numbers, that's not very easy to generate on GANs. So there are other ways like variational autoencoders or other normalizing flows, other ways of doing that, but those are not, I would say, you know, optimal in terms of the state of the art today. So there are a lot of complicating factors in generating representative minority samples. We've been trying this actually. There's a master's student at the University, Katyani Singh, who's been working with me on generating synthetic data to make sure that there is diversity in the healthcare data, which again, we had to simplify it to, you know, very simple types of features, which, you know, is a nice initial study. It's not something that's going to be implemented tomorrow, but it's a nice initial study. And then with the other case of focusing on one type, you know, the majority population maybe, and trying to create an optimal machine learning model there. Well, the obvious ethical implication there is that you're being very unfair. You know, you're really only learning the model for this majority population, and that's the only population you can treat. Maybe that is not an appropriate output for the minority population because, you know, obviously there's all of these sensitive features like gender, ethnicity, all of these matter in healthcare, right? So yeah, there are pros and cons in both. And I don't know what the solution is today on how to do this. Sometimes one thing people do instead of generating synthetic data is they try to boost the minority sample by just upsampling. But again, you're just, you know, you're just repeating those data points. Maybe you're not adding a different kind of diversity, which is not in terms of the sensitive features, but in terms of the actual other feature values.
If I can answer that question more broadly, there has to be a very sound reason to exclude a particular patient group from a research study nowadays. Sometimes I think, you know, in the effort of fairness, the only thing that we can do at this point is actually, how do I put this best? Put a, not a barrier, but forbid any more research on 40 to 50-year-old white men for the next 20 years, right? Like, really, do we need another cholesterol study of? So this also comes back to even granting agencies, you know, actually saying, how are we spending public research money costs, resources in Canada, right? Are we simply funding particular researchers because they've been funded in the past, right? We know that they'll be successful in showing that, this new Lipitor, whatever drug is going to work a little bit better. Or do we actually have a responsibility to now address health conditions in particular groups that have previously been underfunded and under supported? So I say this as someone who works in pediatrics and neonatology, where the vast majority of the medications and treatments we use are off-label because they've simply never been funded in our population.
Panel, I have a question. My name's Jay. My question's about consent. And I'll briefly set it up, and there might be problems with my setup that you can point out. So I live in Alberta. I receive healthcare. There is data collected about the healthcare that I've received and who I am. It's my data in a sense, in that it's about me. It belongs to me in some conceptual way. But I couldn't actually tell you who has my data. I presume Alberta Healthcare has some of it. Alberta Health Services has some of it. Great West Life Insurance has some of it. My primary care provider has some of it. I don't know where it is or what the nature of the data is. It's out there. And so in a practical sense, these bodies manage my data and give access to my data on my behalf in some fashion. In my experience with corporations and governments, they tend to manage my data and assets for reasons that are not well aligned to my own reasons for which I would manage that data. My insurance provider is probably managing my data for profit margin purposes. And that's fine. That's why they exist. I'm not saying it makes them bad. Governments, I think, tend to be very litigation sensitive and will manage my data and protect my data in some cases more actively than I would protect my own data. Michael, you brought this up yourself, that there might be conditions, there might be situations where for my own benefit or for the benefit of public good, I would choose to share something that a government will choose not to share for their own reasons. So my setup is just about done. My question is just about consent. In the Albertan context, are there things that need to be fixed about the idea of consent and the mechanisms of consent for the public good to enable us to do things with data that currently we're being roadblocked from doing? And apologies for the garden path, but there you have it.
I have a question for you. Have you downloaded an app recently on your phone? Have you looked at the long page of terms and stuff you have to go through before you consent? That's basically you consenting, right? So that's just a tongue-in-cheek way of saying that it's a complicated question, consent.
So first of all, I hear you. So when I hear the word consent, I hear it in a very particular way. And I hear it as someone who, has a background in health ethics and health law to a degree. So consent generally means that there's been disclosure of information, right? So the needed information to make a decision I have shared with someone else. That individual has capacity, meaning they can understand the benefits of taking that decision or refusing that decision. And then there's an element of voluntariness, right? So, I'm not basically saying if you don't have the surgery, I'm no longer going to be your physician, for example, right? They have to be free to take the decision or to not. So true consent when it comes to just, your health data going into the system, it doesn't happen. Right? That's very clear. I think the only time we have something approximating true consent is when we're dealing with very particular medical procedures and or surgeries. And even then, often patients actually don't have the necessary capacity. Often there hasn't been full disclosure of information, but rather the patient's making a reasonable decision. So we simply support it and don't question whether consent was actually real. So I think we should point that out. The question of public good, well, who's the one to decide public good, right? Alberta is a kind of a funny province. I was talking to my colleagues at the table who are visiting Alberta, and I said, Alberta is a bit of a funny place. It's the Texas of the North in some ways, right? It seems like our individuality and our autonomy is our primary value or commitment when it comes to healthcare decisions. But I wonder in other countries or other places of the world whether that question would be asked, because ultimately, when you're receiving care from a public health institution, that care hopefully is being given also for the public good. So this data is actually supporting the care of future patients as well. And the whole public system would break down if everyone said, no, I'm sorry, you cannot have my data to do future medical research. So there's a tension there. That's all I want to acknowledge, because ultimately, do we trust the gatekeepers of our health information? Research ethics boards that provide oversight of health research. I've attended those. I think by and large, they're well composed of community members and experts in the field. Do we trust our politicians and our government? Well, no. Anyway, so there's a tension there. There really is. And what do I think needs to happen at this point? I do think there needs to be transparency with regards to however someone is using data, right? That should be able to be scrutinized, right? So all of the different health ethics applications that are currently approved, people should be able to look that up and open up a public discussion around a particular research study if they so choose.
If I can, I'll just point at, I don't know if this is a fair correlate or not, but I have organs in my body that I certainly own, that are certainly mine. In a way that there's more tangible certainty than data, let's say. So these are my organs. And in Alberta, I have to check a box that gives consent that my organs are harvested if I die in an accident.
Currently.
I need to currently opt in to give consent to use my organs. In Nova Scotia, as of 2022, one needs to opt out. It's been flipped. And I just wonder whether you see where I'm pointing with this as far as data and the public good and consent and different ways of looking at it. I appreciate your answers.
Yeah, no, and it's funny. I've done organ donation research, and it's challenging because many of my colleagues in organ donation are saying, look, wait list for infants needing a heart transplant and mortality. If you need a heart transplant and you're a newborn baby, your mortality risk is about 40%. 40%, right? And why is that? Well, for one, there aren't that many donors of pediatric organs, right? Usually the donors are much bigger and their organs are too big to put into a child, a newborn. But also because there's a reluctance to approach people and talk about organ donation around the time of death, right? There's, a lot of, misinformation or a lack of information. I do think that provinces who've moved in the direction, or other places in the world that have moved in the direction of opt-out clauses, that is one step that one can take, but it needs to happen after very real public engagement, because the alternative of moving to something like an opt-out clause prematurely is that you're actually going to lose public trust in healthcare. And ultimately, healthcare is one of the largest investments that we have in kind of public good in Canada, right? And it requires trust for it to work.
Just another perspective to the ethics side of this. You talked about consent to your data. Data is a complicated thing because your organs are your own, your blood is your own, but then there's someone who's taking that, making an analysis of it, and then there's data, right? So I think from a legal perspective, sometimes a claim is made that that's data is not only your own because of that, because there has been done some work, some work has been done on what's your property and then made into something else. So there's some technical legal perspectives on, whose data it might be specifically, or which parts of that data is yours and which isn't.
Your organs, they're your own, but they're not. I'm going to be really honest with you. Like, at what point did your organs become your own? Were you able to actually make decisions about what you wanted and what you didn't want done to them? Yeah, tell that to women. Exactly. All right. Yeah, what's going to happen, Alberta, around bodily autonomy? Don't get me started. But truly, like, when are your organs your own? If you decided right now that, you know what, you're done. You're done with this bleak and crazy, busy world that we live in. You want your organs to cease functioning. You can't do that in Canada, right? Unless you go through, a medical assistance in dying kind of pathway, right? And you prove that your wishes comply with certain societal understandings of what's considered good or bad. So technically your organs aren't your own, right? To do with whatever you want to them, right? So yeah, I don't know.
We have time for one more question.
The slight continuation of of what's been talked about. First off, I just want to say, as someone from the U.S., it is interesting talking about the public health care being one of the reasons for possibly using some of it for public good kind of thing. Because like, despite the U.S. having primarily private healthcare, like, I feel like that's a very valid question in the U.S. context too. But very more specifically, as a follow-up to the prior part, is there any point where, if it's, in this case, we're talking about someone dying and then the organs potentially becoming available depending on opt-in, opt-out? Is there any thoughts on data ownership after death? If you've got a public healthcare system that's got data from 50 years ago, that's a lot of obviously there's some concerns with maybe some of the medical information you could track down to living descendants. But like, is there some idea that it matters less when the patients are dead, or is there a time frame, or is it just treated all the same?
So I would say access to health data for the purpose of research has very tight oversight in Canada. So it's not simply that as a physician who has access to health information, I can simply say tomorrow, I wonder if this is associated with this. I'm going to go check in a bunch of charts. I have to make an application not just to a health ethics board, but
I would say I've done IRBs for like,
oh yeah.
Yeah.
But I'm just framing that from a background. The problem, I mean, so for data when it comes from people who've passed away, right? There is no longer that opportunity to obtain consent for them. So technically, in some ways, you could say utilizing data from someone who's passed away would be easier because you could make a stronger argument as far as why consent would not be necessary. But there would still be a great deal of oversight over if and how such data could be used.
There are some solutions in the non-medical world. Apple has this thing now where you can declare somebody as the person who has access to all of your Apple ID information if you were to pass away. So you could imagine that there are solutions if indeed there is a possibility of your data being your data.
Thank you.
Awesome. Thank you so much, Andre, Nidhi, and Michael. Can we just give them one more round of applause?